Hello everyone, and welcome to the second podcast from the International Society of Blood Transfusion, Transfusion Practitioners Group. I'm Rachel Moss, and I'm a member of the group, along with my colleague Claire, who will introduce herself in a moment. Today in our podcast, we will be interviewing two eminent transfusion medicine specialists who have worked closely with the transfusion practitioners for many years now, and they're going to discuss how transfusion practitioners make a difference. If you're not sure what transfusion practitioners are, you may want to go back and listen to our very first podcast about what is a transfusion practitioner. The International Society of Blood Transfusion, ISBT, is a global community of professionals sharing knowledge to enhance transfusion practice and blood management. The Society does this by providing opportunities in advancing knowledge and education and by advocacy for the welfare of blood donors and patients. ISBT has many working groups that focus on specific topics or areas of practice, and one of those is the Transfusion Practitioners subgroup. So Claire will introduce herself, and after that, I would like our guests to introduce themselves. So Claire.
Hi, my name is Claire O'Reilly. I am the Transfusion Safety Nurse Clinician for British Columbia's Children's and Women's Hospital. But in a way of connecting myself with the people on our podcast today, I will point out I'm very proud to say I am an NHS trained nurse. I trained my general training and my children's training London and Birmingham. And I'd also like to point out the Australian connection is that I did the transfusion practitioner course some years back. And oh my gosh, I just absolutely loved doing that course. So that I think kind of ties us in nicely to show ISBT is truly international. And the transfusion practitioner role is truly international.
Erica, if you'd like to introduce yourself.
Thank you, Rachel, and hello, everyone. I'm Erica Wood. I'm a haematologist from Melbourne, Australia. I work in clinical and laboratory practice and research, and I'm the current president of ISBT. Shubha.
Hi, everyone. A real pleasure to be here. So I'm a haematologist. I've been a consultant haematologist for several years. Initially started off looking after a spectrum of hematology patients, hemato-oncology, hemoglobinopathy, hemostasis, but then moving on to transfusion medicine with a joint post at Barts Health, which is a large trust in London, and also with NHS Blood and Transplant, which is the blood service in England. And great to have been involved in ISBT as previous co-chair of the Clinical Transfusion Working Party, and I completed a stint as regional director for Europe. And it's brilliant to be here today.
Brilliant, thank you both. So Claire is now going to be our question monster, and we'll talk through with both Shubha and Erica the role of the transfusion practitioner and the difference it's made in their professional life. And then at the end of our short podcast, we will round up. So over to you, Claire.
Okay, thank you, Rachel. So we know that there are transfusion practitioners in your country, and what I'd just like you to ask is if you could just share how long the role has been in place. Erica, would you like to go first?
Okay. Okay, so in Australia and New Zealand for about 20 years. In Australia, we started with a pilot in our state, where we had just 2 hospitals and 2 transfusion nurses. Most of the transfusion practitioners in Australia are from a nursing background, but there are some from a medical laboratory science background. And the role is now well established across Australia and New Zealand in many hospitals and also in blood centre settings and possibly other settings as well.
Great. So in the UK, I think it's fair to say that in the early 1990s, transfusion medicine generally was in the wilderness, so to speak. And, there were serious concerns about transfusion safety and indeed sufficiency. And at that time, we were concerned not just about the infections we sort of knew quite well, hepatitis, HIV, but in the UK, we had the spectrum of variant CJD, and we just didn't know where we were going. And so in 1996, the Serious Hazards of Transfusion, the SHOT scheme, the UK Vigilance Scheme, was set up. And following this, we had in 1998 a multidisciplinary seminar, and the Department of Health published the first Better Blood Transfusion Health Service Circular, which I think for the UK is pretty pivotal. And it's pivotal because one of the key recommendations at the time was the Hospital Transfusion Committee. They also urged participation in SHOT and to develop transfusion guidelines protocols. And this is when hospitals started to employ TPs to work with clinical and laboratory teams to support this work. So things sort of started off piecemeal, but then along came the second Better Blood Transfusion Initiative in 2002. And by this stage, we now had the National Blood Transfusion Committee, and the very strong recommendations here was that all hospitals should have TPs. And this is when the role really took off. So that's sort of the starting background, how this role started, I think, in the UK.
Thank you. So I'm going to ask you perhaps to describe a little bit of the role of the transfusion practitioners to the best of your knowledge in your countries. And maybe Dr. Allard, you can go first this time.
Okay, so I'm going to just sort of pick up from where I left off with my story. So we had the second Better Blood Transfusion Circular back in 2002. And then this also, in addition to the TP role, stated that transfusion committees were not enough. You needed the more effective, smaller hospital transfusion team. And the transfusion practitioner was pivotal to the small team, together with the lab manager and a consultant leading for transfusion. And then this then segued nicely into the third BBT initiative in 2007, and then patient blood management. So if you cast your mind back, this is when PBM was becoming an international initiative. So when TPs first started, they were largely nurses, but from many different sort of clinical backgrounds. I mean, I think it's fair to say ITU, renal, pediatrics. And they worked full-time or part-time, focusing on sort of essential activities, working as interface between the many different clinical teams and lab teams, with activities supporting safe and appropriate use, such as guidelines, audit, education, and hemovigilance reporting. And the role has then continued to develop after that.
Okay, and Professor Wood?
Yes, and the experience in Australia has some similarities and some differences with the situation in the UK. We also had a national report which said that we needed to get our act together about how we practiced in hospitals. And I think we all knew that, but it was very helpful to have someone articulate and summarize the issues around clinical practice. So the safety of the blood products was very high already in Australia, but the issue was really about how we used them. And so there was a report published, the report was finally published in its final form in 2005 by the Australian Council for Safety and Quality in Healthcare. And it made a number of the similar points to the Better Blood Transfusion reports in the UK around safety and quality of practice and the importance of hemovigilance. And so we had, I think, an important top-down signal, but we also had a lot of energy and desire for improvement from the individual hospital level and the blood services, saying, how can we improve our practice? And so these things really went together. And then so the role as it has, and it certainly has evolved over the years, it's a very diverse role, and it does depend on the setting in which the person's working and, of course, their interests and background. And as has been said, we've had people from all sorts of backgrounds in hospitals, from internal medicine, surgery, hematology, renal emergency, etc., ICU. And we've also had some people who come into the roles, blood center roles, and the roles are I think there are some common elements in that these are really focused on quality and safety aspects, but the roles are quite diverse, and they're a very important part of the hospital transfusion setting, and different people have taken on different aspects according to the need in their institution. So in some places, there's been a huge focus on things like getting policies and procedures in place. In other settings, it's been reinvigorating transfusion committees, adverse event reporting, education. But most people do something of all these things and are a really important part of the institutional transfusion team.
Thank you both very much. I think that is one of the strengths of the transfusion practitioner role, is the ability to customize it to your health authority or your individual site, so that everybody's getting true value out of the role. So now we did have a question about triggers, but I actually think you've both hit on that. So I'm going to move along, and then my next question is, and or Professor Wood, will start with you, is how did you go about setting up the role? If it wasn't you, it's like, how did others go about setting up this role?
Yeah, so I mentioned we started with a pilot, and that pilot was supported by our state Department of Health. And there in Australia, there are states and territories, and they each have a Department of Health. And then there's also a federal, a Commonwealth level Department of Health. And we've had support at both of those levels over the last 20 years. And that's been really important. In Victoria, where I'm from, we started with this pilot at 2 hospitals for 2 or 3 years. And as we were doing that, we also developed elements that could be rolled out to additional sites. But I'm a big believer in doing a pilot when it's something you've done the first time. So you learn the kinds of things that you should do more of and less of. And how to do them. The pilot was successful, and I'm also a big believer, and this was very helpful in our case, to have concrete reporting to explain what was happening and what kinds of activities were being undertaken and how we could look at progress and success. And so we started with this pilot in the hospital setting. Around the same time, we were also advocating for having similar roles, which at that time we did not have, in the blood centres, saying, you know, there are lots of roles here for transfusion practitioners that could be very, very valuable, but we need to, again, get support from the senior management and explain what's being proposed and what we're hoping to do and how we think this would add value. And so it can take a while to get that support, and it did, but we were very pleased when we had our first teams in place in the hospitals and the blood centres. And of course, Lindley Bilby was one of those very first people.
Okay, and Dr. Allard?
Okay, great. I mean, I think certainly the Better Blood Transfusion Health Service circular back in the late 90s, early 2000s was really helpful in focusing on the needs for hospitals to develop such roles. It was pretty clear that there was a lot to be done in transfusion, but you know, this couldn't be done as a part of anybody else's role where they didn't have time. So having dedicated individuals with the expertise and knowledge was pretty essential if we were to influence safe and appropriate use of blood. And then as these roles started to develop, I think it soon became apparent via audit and data collection that they were pivotal in promoting safe and appropriate use, and in fact were now resulting in a significant reduction in blood usage. And this was really, I mean, it's of course beneficial to patients, but financially, this actually signified really quite a lot, you know, large savings to hospitals. So, so information such as this, I mean, you know, it was shared, and so hospitals started picking up on this, and this actually supported business case cases for development of this role. So by now, of course, we also had the National Blood Transfusion Committee with regional transfusion committees, and regional transfusion committees now sort of feeding into every single hospital transfusion committee. So you had this national framework with two-way sharing of information. And so that sort of also helped promote initiatives such as this, which are, of course, hugely beneficial to patients. And then as part of Better Blood Transfusion initiatives, there were also quite a lot of supportive resources developed as part of a so-called Better Blood Transfusion Toolkit. So there were resources readily available to hospitals and, for example, generic JDs. So this really then helped individual hospitals to take this forward.
Maybe I could, oh, sorry.
Yes, go ahead.
Jump in there. Maybe I could pick up on what Dr. Ella just said. I think until the advent of this role, things like utilization and particularly wastage were considered to be, or at least by default, because no one else was doing this work, were really in the domain of the transfusion laboratory scientists, and they were held responsible for inventory management and blood wastage, when of course a lot of the wastage or avoidable wastage is in fact in the clinical areas. And this has been a very important part of the work, collaborative work in Australia and New Zealand, and I know in other countries, where using the mechanism of the Hospital Transfusion Committee, expecting reporting on blood utilization and wastage, and that for that to be reviewed regularly, it really gives everybody a focus to say, we need to attack all these areas of avoidable wastage. And having a resource, someone with dedicated time from the clinical side to do this work and to support the transfusion laboratory scientists and to feel like a team about tackling these kinds of issues has been so important. And we've been very pleased in Australia that wastage of red cells, platelets, plasma, etc., has really improved over this time. It takes time to show that things are improving, and it can be hard to show what is the driver specifically for the improvement, because in fact many things are often happening concurrently. But having someone to coordinate this work with time in the week, as Dr. Alla was saying, was so important, and I totally agree with those comments.
Thank you both so much, because this is a question that comes to the TP group quite frequently about how to go about setting up the role, and I'm confident our listeners will find all of that information so helpful. Leading on from that is our next question, and Dr. Wood, perhaps you can go first, is how is the TP role supported financially? It comes down to who's going to pay for this. And I know it may differ in jurisdiction, but any comments you have would be helpful.
Yes, thank you. So in Australia, in the public system, the hospitals are run by the state health departments in the different states and territories, and the transfusion practitioner roles are funded by those public hospitals for work in the public sector, and the money comes to the hospitals through the health departments for those roles. Increasingly, there has been uptake of these roles in the private sector as well. Australia has quite a large private hospital system, and the role has shown value for both public and private hospitals. In the first few years, we were very pleased that the role was expanding, but we were living hand to mouth every year to have to advocate every year for continuation of the role. And it took a number of years before this was just part of the furniture, business as usual. And it was quite an anxious time, because people would be getting to the end of 12-month contracts and really not sure if they had ongoing positions. And I'm pleased to say that that is now changed, and the role is as recognized as valuable and as central as, for example, the role of the, diabetes nurse educator or other things that we couldn't imagine doing without now. Infection control nurse, these kinds of roles, whether they're of nursing orientation or not, they are the kinds of roles that we now recognize as being central to quality and safety.
Dr. Allard?
Yes, so of course in the UK we have the National Health Service, but here I'm going to just emphasize, of course, we've got different countries making up the UK, and I'm speaking sort of firstly for England, which is where I am based. So you have several hospitals, and now there are many trusts. So trusts are basically a collection of hospitals within a large trust. The funding for these hospitals trusts is through the NHS, but the budget's devolved to hospitals and trusts, and some more so than others. They're called foundation hospitals. And then we, of course, also have the private hospitals. And within hospitals and trusts, the TP role is funded within those budgets that they are provided. So you don't have a sort of a central pot of funding for transfusion practitioners. So for example, 200 hospitals grouped into 140 trusts or whatever, they would each be responsible for employment of the TP role. But in Scotland, for example, I think there's been a different model in where the NHS, there's been sort of centrally funded transfusion practitioners. I think both models have their own advantages and possibly some may argue there's challenges as well. But I think the important thing to recognize is whatever model of funding, it's the prominence that this role has received across all of the UK. And certainly with successive surveys, we've shown a huge take up. And I think, for example, back in the early 2000s, you probably only have about 15-20% or so with hospitals with transfusion practitioners, and then successive 3-yearly audits. I mean, you're virtually up to every single hospital or trust having at least one practitioner and probably more. And just to really sort of just add to that, I initially highlighted that many of these TPs were from nursing backgrounds, but now I would say a lot of them actually have a laboratory background. So it's 50% nursing and 50% probably at least a laboratory background.
Okay. Thank you very much. Again, the listeners will be really listening in for your information there. The next question is, were there any surprises or unexpected positive effects out of creating the TP role? I guess most people would have what they anticipate or what their goals were. But was there anything that came out of it that perhaps you didn't anticipate? Dr. Allard?
Yeah, so I think sort of having grown up with the TP role, because remember I started off as a consultant in the 1990s, 2000s. So initially, the TPs were, I think, and Rachel will support me, they were very exclusively from a nursing background. And I suppose maybe it's not a surprise, but it was lovely just to see how laboratory-based staff were increasingly attracted to these roles. And I think whatever their background, I think it was fantastic to see individuals showing some really strong leadership qualities. And I think what was also quite interesting to see, and I think this is a positive effect, but certainly some of these individuals then used the TP role as a launch pad to move on to even more challenging development and leadership roles. And we've seen that sort of time and time again. It's always sort of sad when you see a good TP then move on, but gratifying when you see them moving to really quite challenging, significant roles, which they might not have considered before. But I think that's hugely positive that the TP role sort of helps develop people in all sorts of other ways. The other sort of positive thing, really, I guess, is is the overall aim for all this in terms of how much we've been able to achieve in relation to transfusion safety, but also in terms of reduction of inappropriate use. And certainly in England, we've had a 36% reduction in the use of red cells from 1999 to 2019. I mean, I think as Professor Wood implied, this is not just one single initiative. This is due to sort of partnership between lots of clinical teams, hospitals, the blood service. But, certainly in the UK, it's both blood transfusion initiatives and then the PBM initiatives. But, our red cell issues, we were at a high when we first started at 42.7 per thousand population, and we're now down to 24.6. But I think we all must acknowledge the pivotal role that the transfusion practitioners played in all this, and that is just hugely positive.
Thank you so much. And Professor Wood?
Look, I would agree with everything that Dr. Allah's just said, and I would say that in a way the role has been even more positive than I could have imagined. I was optimistic, hopeful, but cautious, 20 years ago. And I think, really what we have now is a strong sense of, camaraderie and support. While this shouldn't be a surprise or unexpected, it's just such a thriving network of people to ask for advice, in addition to medical colleagues and transfusion laboratory scientists and management. It's really a role that brings people together within an organization because they're connected with everybody. I think it's really strengthened these connections. There's also a lot of people really enjoy peer-to-peer connections. So, nurses enjoy talking to other nurses and they speak the same language, and scientists and other scientists speak the same language. So having someone to do that kind of education, speaking the same language and saying, I've been where you are, is very, very powerful. And also, there are so many important projects to work on together, which prior to this role being in place, basically just had not been getting done because medical or scientific staff were really trying to stretch to do them with no allocated time. And then many of these project type activities have become terrific educational or research opportunities and have led to wonderful posters or presentations or publications. And so these have been their own development opportunities, as Dr. Allard said, people to take on more responsibility. But even things that maybe many people listening might take for granted, like going to a conference to share your work and hear from other people, is a very positive development, often for people who haven't had those kinds of opportunities before. And it's really wonderful to see it happening, well, all around the world.
Thank you very much. And last question, Professor Wood, I'll let you kick off, is what advice do you have for our ISBT members and listeners who may be thinking about introducing this role?
Well, it's easy to say just do it, but I really do mean it. You won't regret it. It is hard work. We've all experienced the uphill battle of getting other people interested in why this is important, why it's valued, why it's valuable, and how it would work in the institution where you're proposing it. But I can say from Australia that it's absolutely changed the way we practice transfusion in hospitals in Australia and New Zealand. So my advice would be get other people involved to support you, both formal and informal champions, mentors, sounding boards. We've certainly learned from the experience of other people, and that's been to our benefit. And we've also been able to share our experience. So I think doing it as a team, even a small fledgling team, but if you can do it within your own institution or across institutions, it can make you feel a bit more supported. I said earlier, documenting progress is very helpful to show how things are progressing and to get buy-in from senior management. And I think also to understand that there's not only one way to do this. It's not a single role. There's a variation depending on the need and, of course, the interests and expertise of the people involved. So develop something that works in your health system, in your institution, and learn from what other people have done and tailor it. But start start with a pilot if you think it would be valuable. It certainly was for us, but keep going. We didn't learn all of the lessons even in the first few years, and everything has continued to evolve, but we've been very pleased with how it's worked out, and I really encourage other people to get involved.
Thank you. Dr. Allard?
Great. Those are fantastic tips from Professor Wood. And I would say, there is now plentiful literature and experience about the TP role. And so, for example, the ISBT website has a wealth of publications and experience. And I would sort of, echo what's just been said. And the role may have different emphasis in different clinical settings. So I think it's important for you to define own local priorities. And, by all means, think as big or as small as you like, but make a start. And local data is helpful in defining local needs. The type of hospital, the clinical disciplines, the healthcare professionals involved, get some idea about, local blood usage data, highlight your own needs for guidelines, education, competency, etc. And hemovigilance reporting, define what the role means for you, for your local hospital, what the priorities are. And then identify sort of people who can help you, business managers, but clinical champions. Do you know what? I cannot emphasize enough the role of clinical champions. So for example, in the UK, I think clinicians using high volumes of blood, anaesthetists, ITU colleagues, or not necessarily high volumes, but high risk areas, for example, obstetrics, neonatal, and get them to support you in development of that business case. And once you have that first transfusion practitioner, they can then support further initiatives and further development of the team. So wherever you start, big or small, just make a start.
Thank you. Okay, I will hand you back to Rachel now to wrap up.
Thank you, Claire. As a transfusion practitioner who's now been in post for 20 years, I feel like I've just gone down memory lane, starting somewhere circa 2002 and bringing us nicely to 2022. Dr. Allard, Professor Wood, thank you so much for your time. We really do appreciate it. And hopefully those who are listening who are interested in transfusion practitioner role will just see not only the benefits, we're all champions of it, which is why we're here, but just how diverse and some of the great outcomes. And I just really want to echo that there is not one size fits all. And there are things that perhaps Claire does in Vancouver that I might do in the UK, that perhaps people that work with Professor Wood do, that are all slightly different, but they're all variations of a theme. And I think that's really important. So thank you for everybody for joining us today. If you have any feedback or questions, you can link in with us here by visiting the ISBT website. And as we've already said, there is a huge amount of information on there, including things to support getting the transfusion practitioner role up and running. Do check out the Clinical Transfusion Working Party details. There's a lot of information on there about all things relating to clinical transfusion and our subgroup pages. We look forward to having you join us on our next episode, and we'll focus on some of the specific activities of the transfusion practitioner role, including some tips and resources to assist you. Until then, thank you very much for listening, and goodbye.